Antimicrobial resistance, AMR, drug-resistant infections. Words many have never heard before until it's your father, your child, or your friend whose bacterial infections are unresponsive to antibiotics. According to a Lancet report, in 2019, AMR caused over 1.27 million deaths, more deaths than HIV/AIDS and malaria combined. In Nigeria, AMR was associated with an estimated 263,400 deaths. For nearly a century, antibiotics have been humanity's most powerful defense, saving lives and keeping infections under control. But over time, poor hygiene and sanitation, coupled with overuse and misuse of antimicrobial agents in our hospitals, our farms, our communities, have made these miracle drugs useless. Every year, thousands of Nigerians battle infections that refuse to heal. But amid the chaos, there are stories. Stories of survival, resilience, and the fight to protect antibiotics. Follow us on this journey into the heart of antimicrobial resistance, told by those who have lived it, fought it, and are determined to change it.
I am Mashood Olukulawal. I'm in Nigeria. I like to tell everybody anywhere I went to that I'm in Nigeria because I'm proud to be in Nigeria. And I'm a clinical pharmacist by training. I worked at the Federal Ministry of Health mainly. I trained at University of Nigeria in Nsukka. Between 79 and 84 I was at University of Nigeria. And thereafter I went for my internship at a General Hospital in Kwara State. After there I went for my NYC at a village called Ubukwan, very near my school at Nsukka. After that 1 year I returned to my state, where I started working at the General Hospital Patiji. I'm someone who liked to work. Where when I was posted to Patiji, I was virtually redundant. It was a general hospital, possibly the best hospital in Kwara State by then, outside the teaching hospital. But I was redundant in that we don't get patients to attend to. So I left the state service to join a private pharmacy known as Sekundayo Pharmacy in those days in Ilorin. For those who are familiar with Ilorin, it was the leading pharmacy in Ilorin by then. After some months, we parted ways, and I found myself, with the grace of God and the support of families, members, employed by the federal government of Nigeria, and I was posted to the Federal Ministry of Health. So there I began a career from 1987, to be precise, July 13, because that's what my record says, although I got my letter, July 6 or 7th, but they only record the day you assume duty as your date of employment. And I rose through the ranks to become a director in 2013, became the head of the Department of the Food and Drug Services 2017, and retired October 2020 during the COVID era. So that was my career in public service. And since then, since 2021, after a brief rest and a survivor, I've been working as a consultant for the Commonwealth Pharmacists Association on the Commonwealth Partnership for Antimicrobial Stewardship Program known as CW PAMS in Nigeria. We do the council of the Pharmaceutical Society of Nigeria. Anybody in the medical line, a medical doctor, a pharmacist, a nurse, a microbiologist, we definitely must have learned about antimicrobial resistance in the course of his study. We were taught of cross resistance between the ampicillins and all other drugs. Although by then it was just briefly, because it was not a major issue as at then. So that is when I first learned about antimicrobial resistance. But as it became a global issue and a threat to the survival of humanity, I got involved. Again, I said I was Director of Food and Drug Services. My department was deeply the NCDC, the Nigerian Center for Disease Control and Prevention, that is now shadowed with the responsibility of organizing our efforts on antimicrobial resistance, was actually a part of the ministry, the EPIC unit of the ministry. And I was part of the long debate in the ministry and efforts to create the NCDC. So at that time when antimicrobial resistance became an issue, I was already a privileged member of the ministry top management committee meeting. Though I was not the head of department, but I have the privilege of being in the committee meeting, the week in, week out. So I became aware of the global effort. And as someone who is very, very, conversant with global trends, apart from being a medicine, I'm a pharmacist, or having the opportunity to be among the leadership of the ministry, I became aware of the global attention, renewed global attention on the surge of the antimicrobial resistance. I think it's very important to tell you my story. You try to paraphrase it, but as the Yoruba says, I mean the Englishman says, it is he who wears the shoe that know where it preaches. So my experience we started on a very early morning, July 2020. I woke up with a very terrible pain by the lower right side of my stomach. I was an ulcer patient, that was a complicated ulcer patient, which I survived. So when the pain came, I knew it was not ulcer patient. Life number one, from the position, my ulcer always stand on there and radiate to all other parts of the body. So the pain, I was on the bed for some minutes when it was not going. What will I do? I picked Miss McGinnis translocator and took some. I was not expecting relief, and I did not get relief. So at that point, I moved out of the bedroom because I was on the bed with my wife. I was not shouting because I'm not a baby. And sorry for the women who fuck, I'm not a woman. Because with some women, they will be shouting, because that's their nature. So I gently crawled out of the bed, went to the sitting room. At that point, I realized that when I was doing community pharmacy, I'm the one who will advise people that whenever you have pain, at least first take paracetamol. If you don't get relief, then you can consult. So I took 2 tablets of paracetamol. And it was like a magic. The pain subsided almost completely. And I drifted up. I slept again on the 3-seater in the room. It was at that point my wife woke up and discovered that I was not on by her side. She came into the sitting room, met me sleeping. So the time she woke me up, it was like waking me up also woke up the pain. So I was trying to explain my situation to her. The pain came up again with the same intensity. So I told her I was going to National Hospital. That was getting around to some minutes to 2 a.m. Meanwhile, I had a friend by then who was a senior member of the National Hospital. I called him. I was coming to National Hospital. She please meet me there. He lived in the town at Games Village. I live at Lugbe, the outskirts of the city, on the way to the airport. So we got to the National Hospital. I went to ultrasound twice. They could not see what was wrong with him. The pain was still there. At the end of the day, I was given a dose of diclofenac IM, and the pain went off. But the management there discovered that I decided that it would not allow me to go home. I was to be subjected to observation at least for a day. So I was admitted. And throughout the day until the following morning when I was a child, there was no pain again. However, I was advised to go for CT scan. So which I did, I think the following Monday or so. And it was the CT scan. When I went to the private diagnostic center, I also did an ultrasound scan. The only which they were not able to note that there was something in my kidney. But the precise thing, they were not sure. But the CT scan revealed it was a kidney stone of 10 mm, that is about 1 centimeter. For those of us who are learned about the structure of the kidney, that was really big for the tiny tubules and all those things. Yes. So at the end of the day, the diagnosis was known, the ailment was known, the management is either to open it up or go through the modern technology, which is a laser technology known as lithotripsy. I opted for lithotripsy because it offered me the advantage of going home after 48 hours. No catheter, no urine bag, nothing. Unfortunately, it was not available in any of our hospitals, including National Hospital, where I was taken. And I opted for a private hospital. We did it. I was taken in August now, mid-August 2020. I was taken to the theater under heavy anesthesia. But about 3.5 hours later, my wife was summoned in. I signed my initial consent to be taken in for some. To come and either sign another consent or they release me from the theater. Why? Because the technology failed them. They could not crush, the technology will reduce the stone into powdery form, which I'll be able to bring out in my urine. But they said a bit of it got stuck, which we actually saw at the end of the day. So it was a bit tiny, but at least it was something that could still give me trouble in the future. So my wife opted that they should open me up. That's how I was opened up. And I woke up the following morning, surprised that they opened me up, and she explained everything to me. It has been done, I can't turn it back. And she took the right decision. So at the end, I was placed under heavy prophylactic, post-surgery prophylactic with augmentin, 1 gram, and metronidazole IV. I later switched to the tablets for both. And I was in the hospital for about 9 days. Discharged later with catheter. We stayed with the drugs. And I think a week or two later, the catheter was removed. And I was all right. But in the process of my stone developing, water had gathered in my kidney, known as hydronephrosis. And they could not leave that water there. So a stent, S-T-E-N-T, a very tiny tube, was inserted between my kidney and bladder to drain the fluid. 3.5 months later, I was asked to report back. I did an X-ray which showed that the water had completely been drained. So I was scheduled for a Saturday on 23rd of November 2020 to remove the stent. I had a very light anesthesia. Light in the sense that after the whole process, after 2 hours or so, I drove myself back home. So that's how light it was. Although it was against medical record advice. But I felt I could drive. So, because I drove myself away. And I didn't have my wife to drive. She can drive. It would be like me too driving. So I opted to drive. And there was no problem throughout that day. But by Monday, that was barely 48 hours later, I started feeling cold. I was shivering, elevated temperature. I was in the bedroom. And I went to my wife, who was in the kitchen right there. Was the weather cold? She said the weather was not cold. I was the one that was probably sick. And prophetically, it turned out I was really sick. And it was the beginning of a long and torturous journey. So later in the day, I took anti-malaria. Don't forget, I'm a pharmacist with a very long period in community pharmacy practice, coupled with my ministry work, which I did to survive. So, as expected, with paracetamol, I had some relief. Later on, I went for the symptoms came back. I now went to our local laboratories, one of our local laboratories, and I did a test, which shows, as expected, typhoid and malaria. And looking at my recent exposure to augmentin, I opted to take ciprofloxacin. I took the leading brand in Nigeria, Ciprotab, and I changed the ACT combination to another combination. I took it, I felt all right. I was on the second packet of the ciprofloxacin by 14. So that means I've taken it for over a week. When the symptoms returned, So at that point, I had to call my consultant, the urologist who handled my case. He advised I should go back to augmentin, 1 gram, which I did. I was on the second packet when the symptoms returned. After I felt out, I was doing well. So I called him again and he said I should return to the hospital. I now did culture of my urine and it turned out to be heavy growth of Escherichia coli, a urinary tract infection. So the symptoms had established apart from feeling cold. When I want to urinate, I feel sharp pain in my pubic region and all those things. So, and it was sensitive to several signs. I took the leading brand, Sinat, 500 milligrams, and it was as if it was programmed. On the second packet, the symptoms returned. Around that point, a very close friend of mine called my wife. And my wife told him, your friend is still very seriously sick. And he lived in the town area 3. He came down to Lube. We are very close. He came to my bedroom. He was with me on the bed for about 2.5 hours. We were chatting and all those things. As he was leaving, he told me he was going to buy drugs. If not for my sickness, he would have asked me what would he take, explain his sign to him. But he didn't tell me. And I didn't ask him because of my state. So it's because he told me he was going to buy drugs. So a few days later, he apparently bought his drugs. A few days later, he traveled to Omi, which is Iloni. And he broke down. He was taken to hospital, eventually diagnosed of having contracted COVID-19 infection. So a few days later, I had a terrible dream that actually died. And they had wrapped my corpse in a green cloth, shiny, bright color green cloth. And they were taking my corpse to the grave. But when they got to the graveside, they put my corpse on the ground. And at that point, I started shouting, water, water in the dream. When I woke up, I didn't tell my wife the dream. Because we used to tell ourselves I do. But this one that I died, I could not have told her, and I didn't tell her. So I told her I was going to do COVID test. She said, you don't come. You are talking of antimicrobial resistance. You are talking of COVID. I said, if you don't want to go, I will go. She said, you should call my driver. Don't forget I retired in October. You are talking of now January. January 2021. So she called my driver. And my driver was free. So he came down to pick me in my personal car. I'm out to the reference center at Gadua. Don't forget I just retired. The connection was still there. The DG NCDs by then was a friend. The director of the lab was a friend. We had worked together separately. So please just so we want to they quickly attended to me at the reference lab. I was tested, my driver was tested, my wife was tested. My driver was positive, I was positive, my wife was negative for a purpose, so that she could take care of me. And we were only 2 at home, just as we are now. We were only 2 at home. She didn't meet her now, she's gone to our shop. So now I had to be isolated. That was referred. I called the Director of Hospital Services by then in the ministry. She spoke with the permanent secretary, who were all my friends and colleagues. And I was referred to the Asokoro Isolation Center, which I was part of those who accredited it as an isolation center. So when they got there, they listened to my medical history and said, I got a director, we can't take you here. So I had to come back in the ministry, and I was referred to the general hospital. So I got to the general hospital. They already was expecting me. So I was admitted, and my journey began. The first 2 days, it was like a small thing. But by the 3rd day in the evening of my admission, I started breathing like a cow. The nurse said, Mr. Lawal, are you asthmatic before? I said no. That's how I was placed on oxygen immediately. So I was on oxygen for over a week. And I was placed on various forms of antibiotics. You know, the word was confused. I was on meropenem and so many other things, just to get me under control. Eventually, I survived it. And the water I was shouting in the dream, I actually drank the water in real life. What happened was that one of the signs or symptoms of COVID is a cough. So my own cough came up, and it was persistent. I had to tell them, use this particular drug for me, which I don't want to mention, because I don't want people to abuse it. It's a drug that could be abused, because it's an unlicensed indicator for it. They said, Director, we have called you, we have used this injection for you, we have used the tablet for you, it didn't work. So I started taking water, which we believe in Yoruba mythology that it can control thought. So I just open a tray of nesting water by my bed. I will open all the bottles. Because as I'm gulping one down, I take another one. That was my sustenance. And I was urinating on my body. Because the strength to go into the toilet that was inside my room, I would not leave my bedroom to another place, but I could not move. So that's how I drank the water. Eventually, thank God I survived COVID. But my AMR, which I also did another test on, I did urine and blood culture, and urine turned out to be, again, the same Escherichia coli, every growth. Now sensitive to levofloxacin, from ciprotab to augmentin to cephalosporin, that's a Sinat, now to tafanic, levofloxacin. They gave me the IV while I was still on admission. They gave me the serum injection. They gave me the tablet. And I was discharged home with the tablet. I took it for 5 solid weeks. When I felt there was no improvement, when I eventually went for a repeat of the culture, it still turned out to be heavy growth of Escherichia coli. So no change at all. And the symptoms was persistent. I could not eat. When my wife brings food to me, I say, please take it away, take it away. If eventually we negotiate and we eat the food, I will say, take the meat away. So that's how terrible it was. But now, I went back to my consultant, and I said I should go and do another culture test. I now went to a very big private laboratory on his recommendation in Abuja. They now said it was no longer Escherichia coli, that it was Staph aureus. But it was resistant to virtually all the drugs. You are confused. But they said, they now advised me at their own cost to go and repeat the test at another branch of theirs in Abuja, which I did. And the result turned out to be virtually the same. It was as if they copied themselves. At that point, I went with the 2 results to the consultant, who now told me that it was a contaminant, either in their specimen bottle or in their microscope, that it cannot be staph. So he now directed I should go to another private lab. I will not mention it because it will mean as if I'm promoting them, but they are doing a good job there. So, and it was there they reaffirmed that it was still the same Escherichia coli, now sensitive to some carbapenems, including meropenem was no longer there, and so 1 or 2 other antibiotics. We debated within myself and the consultant, and it was because the chief technologist or the chief microbiologist there advised that in addition to these drugs, fluoroquinolones can also be very useful for it. So based on that, and based on the need that I will have to be hospitalized, if I'm to take the other carbamazepines recommended that came out of the test, the consultant felt I should continue with levofloxacin that I'll take it for 5 weeks. My wife now raised a question. To continue with levofloxacin, that she says every growth, no change at all. So when I got back home, I opened my books, pick up my handset, Google deeply, and I discovered a particular antibiotic among the ones that it's sensitive to. That said it was very specific for multi-drug resistant Escherichia coli. So I called the people in Abuja who said drugs. Don't forget, I was the director of Food and Drug Services, so I knew everybody. So they told me they have the drug. I won't mention the pharmacy name. I now called the consultant, and he said, I can try it. My wife wanted for us to go for it that night. I said, no, let us wait the following month. So we went for it. The two forms available were the injection and the effervescent powder. So I went for the effervescent powder. The dosage schedule is between 48 hours or 72 hours interval. To me that was sick, if it is every 1 hour, I'd be glad to have it. So I took the 48-hour schedule. The first dose, there was a marked improvement. Second dose, I didn't feel any symptoms again. I took the third dose. That's how I became well. My urine was suggested to test. It was sterile, no antibiotic, no single one was found there. And since then, before then, I've never had any urinary tract infection. And post then, I've never had it. But tragically, my AMR survived my COVID. I've said the story. For those who are the medical line, they may have a feeling of what I've gone through. But nobody can tell you, as the Hausa people say, many Afiji, you know, you are talking about Juba. You see, who have gone to the war, they can really tell about the war. It was not a very pleasant. It was not pleasant at all. I lost my mother. I'm from Ilorin, as I told you. I could not attend the burial. I could not attend the 8-day prayer too. Because it was not just possible for me to travel. The lucky thing that they were used to my traveling and not attending some of the family functions. So they just told them I travel for an official function. So it was a learning period. And it emphasized two key things. Number one, standard. We must enforce our standards. It's better to have few laboratories that are operating with the necessary standards. The local lab where I did my test, I said 90% or 99% of them we always say typhoid and malaria. We need to enforce the existing regulation on them. We don't just set up any mushroom thing. Because misdiagnosis could cost somebody his life. Then the big multi-million naira lab, where I was also misdiagnosed, also shows that our system require, or our health workers require training. We must, because morphologically, there's a big difference between, they are not related, a cocci and a bacillus. Staph is a cocci, Escherichia is a bacillus. You see it, one is like a rod, one is like a point. So there is no reason how they will mistake, they should mistake an Escherichia coli for a staph. So it means that we need to train, constantly train, and possibly test their knowledge before we expose them to do public work. So that was my experience with COVID. And it was as if God was preparing me for a role to play in global effort to reduce it. We cannot eradicate AMR because it's a natural phenomenon. It's the survival instinct that the Creator has given to the microorganisms. Except we want to eradicate microorganisms. That we infamously also eradicate humanity. Because humanity also needs microorganisms to survive. We have the commensals in our stomachs and on our skins. Those who bleach their skin, you see what happened to them? Because they have reduced or killed the commensals that protect them from things. So it's as if nature or God on His Majesty was preparing me for a role. And it has, since then, while I was still recuperating, I got this job of working with the CPA. I never applied for the job. Someone recommended me for it. And it has taken me to places. I've contributed. Now I'm not a member of the country's technical working group on AMR and AMS. I'm now a member of the WHO task force of AMR survivors. So that is how far AMR has taken me. And as a pharmacist, I've developed myself, read so much about AMR that I'm in a position to eradicate, not to educate, create awareness, and join, which I'm doing, and which I'll continue to do, the national efforts in controlling AMR. So that's my story. Thank you for giving me the opportunity to state it again, as expected by the WHO. And I want to state, 12 of us were constituted into WHO Task Force of AMR Survival in 2023 October. My case was the least, as far as I'm concerned. Imagine someone who had multi-drug resistant tuberculosis. Tuberculosis that is not multi-drug itself is wahala. Imagine someone who had an accident, motor accident. Sister, the whole thing became infected. And one of the infections was a muscle yeasting infection. Or a veterinary doctor who just fell in his bathroom, developed a fracture, got infected. Or an athlete in US who had a heel injury, and the whole of US, no antibiotic could treat her after spending hundreds of thousands of dollars. They are now to be doing an experiment with probiotics with her. So that's why I say my case, I consider it the least. But as frightening as my case, so AMR is something which, number one, try to prevent by preventing infection in the first place. Prevent infection, simple principles and concept of watch, hygiene, cleanliness of environment, cleanliness at home should be taught from home, from the small age, so that it become a culture for us. Spitting in public, what call it, open defecation. We need to work against it in this country. I'm sure if we eradicate open defecation in this country, incidences of typhoid will go down to almost nil. So we need to work on those issues to reduce incidences of infection. At the end of our hospital, IPC must be improved. Water supply must be made number one. What call it, protective measures to protect the hospital workers, to protect the patients that are coming. My own case looks simple, as I said. I was told of a couple that have been looking out to God for baby. They had the baby after 9 years. It's at UCH. And after 9 years, the baby was admitted in intensive care while he was on a what do you call it, during the process of delivery and taking care of her. She got infected and it became resistant. Most hospitals acquire infections have the tendency to be multi-drug resistance. Now they lost the baby. You can imagine the pain that they went through. And I don't know their state as of now. So it's very, very important to improve on our IPC and other measures to prevent infection. Thank you for the opportunity, for hearing me out. And I hope the little I've said will also encourage the Nigerian populace to know that we do not misuse antibiotic, number one. We only take it as necessary. And I think we are beginning to make progress on the application of antibiotics through the national effort on antimicrobial stewardships. And it's based on the program which I'm involved, CWPATS. In the 5 centers and the associate hospitals that are working with the 12 others, we have made tremendous progress with the support of NCDC. Thank you for the opportunity. A major cause of antimicrobial resistance, which is when you use antimicrobial, not only antibiotics, because when we talk of antimicrobial, we are talking of a range of things. The antibiotic, the antifungal. I will use an example of the common ones that our people know. When you talk of antibiotics, we are talking of our ampiclox, our tetracycline, our chloramphenicol, our ampicillin, our chlorcecillin, those are the common ones. Or our ciprotab, those are the common ones our people know. But when we talk of antifungal, which is another antimicrobial, we talk of the one that they used to know in those days, fusin. I don't think they mention fusin now. The one that is in trouble now, is ketoconazole, which is danger. People, because they don't know. Because they don't know that when you take ketoconazole beyond 14 days, you risk damaging your liver or kidney itself. So, now, then the antivirus, which maybe because they don't have access to it, they are not misused, all those things. So, one of the factors that encourages or that leads to spreading of antimicrobial resistance is the misuse and overuse of antibiotics. Misuse is that when you take antibiotic or antimicrobial when you don't need it, the fact that you develop running stomach does not mean you need antibiotic or antimicrobial. God in his infinite mercy, God so loved mankind that he has given us some protective mechanism in our body. If you have taken a food item that will cause problem for you, God has created a system in your body to protect you. I discovered that by the time you go to that, you purge for 1 or 2 or 3 times, and you take ORT, what you call ORT, just to replace the fluid you have lost, your system will have taken care of itself. So there will be no need for you to take metronidazole, Flagyl. A tablet of Flagyl does not leave your body for weeks because it has a prolonged half-life and all those things. So, and by the time you don't take the correct dose, you already signal the organism, the microorganism. And everybody wants to survive. Everything that God has created has also been given a survival mechanism. So it's like it has tested it, and it will try to protect itself. So next time when you need this drug, and it's even prescribed for you or recommended for you by the right person and the right quantity and dose, it will not work again because the microorganism in your body has already developed what you call resistance to it. So my advice for people is, number 1, when they fall sick, they should not just take drugs. The first thing I advise them to do is to go to the nearest health clinic near them. The beauty of this nation is that each political ward in this country has an health clinic, primary health care. And they are trained people. They may not be doctors. They either be nurse or community health workers that have been trained to handle simple things. So they are there to guide you on the right thing to do. So that is it. And when we take antibiotic, please, if they ask you to use for 5 days, use it for 5 days. Don't just use it for 2 days and say you are no longer feeling the symptoms and you stop it. And we should not share antibiotic with somebody. Because the fact that you have running stomach does not mean the second fellow having running stomach 2 weeks later he's suffering from the same disease from you. It could be a different thing. So let that fellow also go for advice, medical advice, on how we will treat his running stomach or all the other things. You have malaria, yes, you can take anti-malaria. But when you take your anti-malaria 2 or 3 days and you are not getting relief, please don't go and look for Ciprotab and start taking it. You should know there is need for a superior advice, an expert advice. So please go to the nearest health clinic and tell them your medical history. This is how you started, this is what you have done, this is what you have used, and this is how you are feeling now. So that is how you should do about it. The terrible thing about antimicrobial resistance is that the amount of antimicrobials used in the farm or on our animals is far more than what human beings use. So we are having more pollen from the agricultural hand than maybe from human health. So the advice I want to give, number 1, is for our farmers, both those who involved in animal husbandry, fishery, goat rearing and all others, snail rearing and all those things, is number 1 to make sure a clean environment for the rearing and growing of their animals. And then they should seek professional advice. So that, because just as resistance develop in human being, it's also developed in animal. And then the worst thing, or the most dangerous thing is that the antibiotic you use for an animal, when the animal is eventually consumed by man, the antibiotic settle in the man as residue and stimulate the microorganism in man, in the human being, to become resistant. So we have the problem getting heightened, getting complicated, simply because we want to feed ourselves. And it is good for us to produce more than try to hasten growth through antimicrobial resistance, antibiotics application. So that's my advice. And I want to also encourage the government to let us improve on our, what is the word now? There's this veterinary people that go around. So there's a word for it. They go around communities, they go around. So people want to go into animal rearing, should register with appropriate section at the local government level, so that the appropriate health workers can pay regular visit to monitor progress or help them address problems and challenges that may crop up. I will say our case is more tragic. Tragic in the sense that we are knowledgeable. It's that we don't know. We know. But somehow, we fail to do the right thing. But things are changing. Changing in the sense that with the global focus on AMR and addressing it through antimicrobial stewardship program, people are beginning to have a rethink. The people, the health workers, the prescriber, the nurses, the pharmacists, normally you have guidelines. Guidelines are not just developed. They are developed based on certain data and observation. So, but people prefer to diagnose and to treat empirically. And in doing it, they don't also follow the guideline. They try to go for the newest antibiotic. They try to go for the super antibiotics. And in the real sense, there's no super antibiotic. An antibiotic is as good as the other, as long as the antimicrobial is responsive to it. So, with the education and engagement on antimicrobial stewardship, people are beginning to follow the appropriate guideline procedures. Yes, we cannot leave a sick man untreated while we await laboratory results. But in doing that, we should be guided by the guideline on which drug we use. That's what we call AWARE classification of antimicrobials now. The access one, which are the common drugs that any disease we can find a suitable drug to treat. And it is expected by 2030 by the WHO that 60 to 70% of our prescription, empirical prescription, will be based on this AWARE classification. So let us restrict our empirical treatment to AWARE classification before we move to, watch. And then watch possibly should be when after laboratory diagnosis. So this goes to the need for us to make use of our laboratory in our institutions. Let them do the test, let them show you. There was an experience where we were told in a LUT, where the consultant said they have been treating this patient with so many drugs, no response. But when they went to the lab, it turned out that it was common. Let me use the word common because that was how they felt. Cold tumors and so. That was the solution. And when they used it, the patient cases was resolved. So the danger of antimicrobial resistance to healthcare is that in most cases, it's not the primary ailment that took the patient to the hospital. So he hardly, I don't know how to describe it. We can't call it a super infection. We can't call it a super disease. But when it comes up, a lesser attention will be paid to the main ailment. You get it? It was COVID that took me to isolation center. But they had to attend to my AMR. So it is very important to do as much as possible to reduce the incidences of AMR.